All right, good afternoon, good morning. Welcome everyone to today's webinar on promising procurement practices. This is our third webinar in a series of 4 highlighting achievements in EHE. Today we are going to have some jurisdictional examples. We're going to be sharing some survey results, questionnaire results, as well as talking about some promising practices. And we're also going to have some space for some peer-to-peer learning where we'll break out into smaller groups so that you all have an opportunity to speak with your colleagues about what is happening in your jurisdictions. So just quickly, just a brief overview of NASTAD and our role in EHE. NASTAD is a national nonprofit organization. We are the TA provider for EHE implementation through CDC's PS 19-1906. And we also provide support to HRSA-funded jurisdictions through our systems coordination provider project. And also want to let you all know for the final webinar in this series, which is going to focus on blended funding, that will be held on Wednesday, May the 29th. And I will put a registration link in the chat shortly for that as well. And yes, we will be sharing today's recording and slides. When we go into our breakout groups, Zoom does not record that. However, we will be using the AI companion to take notes, and we'll share those out with folks who registered. So these are some results from a brief questionnaire that NASTAD sent out back in March of this year. And it was sent through NASTAD's EHE listserv to CDC and HRSA-funded EHE jurisdictions. And we were hoping to learn about your EHE activities, what EHE funding is being spent on. And so we had 16 EHE jurisdictions who completed this. And so as you can see from this bar graph, on your left are those activities that are most common among jurisdictions. Most of you are spending your funding on social media and marketing, on your sub-recipients and your contractors, on community engagement efforts. And then as we go along, you can see, on the right side, things that are less common. And so we're hoping today that you all will get an opportunity to talk to each other about what have been your challenges, what have been your successes. But you can see that on the right, on the lower end, folks, jurisdictions are not, fewer jurisdictions are spending their funding on mobile units or telehealth or SSPs. And then in the middle, you can kind of see that testing, provider education, support services, prep programming, data systems, mobile units, those kinds of things are kind of about roughly like 50% of jurisdictions are doing those activities. And then a couple of other things that came up. We asked you all, what are some low effort or quick turnaround time activities that you all are working on? Most of you said social media and marketing are kind of the easier things that you were able to do. Also using funding for supplies such as safer sex supplies, tests, educational and promotional materials. And then also adding funds to any existing contracts that you may have is also a little bit easier to do than, for example, on your right, you can see the high effort or long-term activities, which is starting new contracts or funding new services or activities. Mobile units, that is something that a lot of health departments said that they are struggling with. So we're going to be hearing from a jurisdiction who is doing some great work with their mobile unit program. Rapid Start also is something that takes a lot of time to set up. Workforce development, a lot of HR policy related issues that often come up for health departments. Provider education and engagement, which many jurisdictions struggle with, and then early intervention services. So, and we can share these results with participants in the follow-up email as well, so that you all can see some more details. So now I'm going to, we have some two health departments who are going to kind of talk briefly about their efforts as far as spending EHE funding and procurement. So I'm going to invite our colleagues from the Los Angeles County Department of Public Health. And I believe I saw Michael is on, so I'm going to pass it to you, Michael, to introduce yourself and talk about your jurisdiction's program. Thank you so much.
Thanks so much, Krupa. Nice to see everyone. Michael Hamer, pronouns he, him. I'm the program manager for the treatment and respond pillars for our Ending the HIV Epidemic initiative here in LA County. And I'm going to be sharing about our third-party fiscal administrator partnership. So as we all know, given the launch of EHE shortly before the COVID-19 pandemic, LA County identified the need for a third-party administrator in year 2 of EHE. And this is really due to the delays in spending and program implementation related to the pandemic, but then also to some of the subsequent freezes in county processes. Our plan here in LA County consists of 25 different strategies ranging across prevention, treatment, and supportive services. And we really thought we needed to get creative in order to have timely implementation of all of those strategies. So the goal of our third-party fiscal partnership was really twofold. So we wanted to quickly identify and subcontract with agencies versus the typical lengthy county solicitation and contracting processes. And then the second one was to identify new and non-traditional partners, which was one of our goals through EHE. And we really wanted to reach those partners that typically can't meet the county's minimum mandatory requirements, but really have the potential to contribute to the EHE goals in our jurisdiction. So in June 2021, we developed a proposal for a sole source contract with a local nonprofit organization. The organization is Haluna Health. And our goal was to have them serve as our third-party fiscal administrator. And the reason for selecting Haluna Health specifically was because they have significant experience as a third-party fiscal administrator across the state of California. And also their president and CEO has experience with HIV, having worked with the New York HIV program in the past. And also they had good standing with LA County Department of Public Health. So we thought that that would be a strong partnership moving forward. After identifying them as a strong partner, obviously we needed to get buy-in from our leadership, not only within our program, but also with the County Board of Supervisors. So as we know, that process can take some time. Obviously, we want to make sure that everybody is on board, but we were really lucky that and thrilled that we were able to not only get the contract approved, but also executed in June 2022 and really just hit the ground running from there. In terms of kind of building out what our partnership would look like with Haluna Health, we developed a scope of work that was based off of activities we felt that would be really a good fit for them and also for us to be able to establish that partnership and have a good working relationship. So since then, Haluna Health has subcontracted with more than 30 organizations to support our EHE efforts in LA County, and they're helping to implement several EHE strategies. I'll just give you sort of a short list, but some of the ones I felt were some of the ones I wanted to highlight. So we've been able to award mini grants of $50,000, as well as recently innovation awards for innovative projects. Implementing evidence-based interventions addressing trauma and mental health among people with HIV across 9 different agencies, increasing HIV workforce capacity through an annual conference and tailored technical assistance to agencies and providers, recently 6 new street medicine contracts, which we're excited to start implementing this month with the agencies and alongside Haluna Health in partnership. And then finally, a PrEP detailing campaign that has been successful in reaching primary care and women's health providers. And then I just wanted to highlight sort of the nuts and bolts of what that relationship looks like between Haluna Health and LA County Department of Public Health. So basically what we do is we meet weekly, a planning meeting actually in 2 hours. So we meet with their team. We have not only our contracting team, our contracted community services partners within LA County Department of Public Health, but also our programmatic leads join that call as well. And then from Haluna Health, they have their contracting team as well as their leadership. And then they have program support that supports us in not only getting those contracts on the out into the community, but also working directly with the partners to be able to implement these programs. You know, I think Successes, I think it's a great partnership. I think the working relationship is wonderful. I feel like we've been able to meet those goals. So we've been able to get the funding out quickly into the community, but also bringing in new partners that for DHS, for the LA County Department of Public Health, I don't think we would be able to establish these partnerships without our partnership with Haluna Health. And then moving forward, we're moving into the future, we're looking at supporting this partnership in the future, regardless of the funding streams. But we really think that this is a successful model that we hope to continue into the future.
Great, thank you so much, Michael. For our participants, please feel free to use the chat or the Q&A function to ask any questions that you may have. And I'm going to have our next health department talk briefly about their mobile unit program. And then once they are done, then we'll address some of the questions that we get. So I'd like to welcome our colleagues from the Houston Health Department now to introduce themselves and talk about their mobile unit program.
I'm Amber David. I am a coordinator for most of our community events and have been leading out the mobile unit team for about 25 years. So I'm a senior public health investigator.
Hi, my name is Alma Williams. I'm a training administrator here at the Houston Health Department. I'm fairly new, so Amber is the expert in everything mobile unit.
Yeah, so I guess we were just going to talk a little bit briefly about the history of our mobile unit. And myself, I have been on board with the mobile unit team since 2000. So that will be my 24 years out there. And we consider our mobile unit a satellite clinic. And it's guided by our surveillance teams where we see prevalence of STIs in community. So our goal is to go out to community and raise awareness on STIs in a specific area and the prevalence of STIs, to test for STIs, but to also raise awareness on transmission of STIs. It's because many times the community may think that they are not a candidate for contracting STI because they're not really aware of what the modes of transmission are. So our mobile unit will go out and do pretty much, we site where we're going to go, we go out and do site visits. So when we are looking for a site in a high prevalence area for gonorrhea, chlamydia, HIV, we go out to community to collaborate and partner with our community partners. Mainly our collaboration starts out with how and where we would park our mobile unit. It being a 40-foot unit, we have to make sure we get out and can park it in a high prevalence, high traffic area. So we tend to go to community to raise community's awareness on why we're out here and what we're bringing as a service as the Houston Health Department. So we talk a lot about prevalence, and so the community know that we're out there trying to interrupt disease, but raise awareness. We try to look at all demographics as young people, as much as seniors. So we specifically target areas for different demographics in a high prevalence area and in an area that may not have a health center in their community. We had a mayor, about 4 mayors back, wanted to make sure if we had what we call healthcare deserts, because we do go a little rural, that we were going to communities that may find it hard. Sometimes with seniors getting transportation to one of our multi-service centers. So we specifically go out on purpose to be there to provide services. But I just want to keep reiterating that awareness of modes of transmission and the prevalence of STIs is as important as bringing testing to the community. And I think about young people a lot. Young people may think they may not be aware of parasitic STIs and maybe the modes of transmission being hands, fingers, and broken cuticles and those kind of things. I'm very excited when I can have a young person know that you can contract an STI through broken cuticles. And so that's our younger community. And with our universities here, we go out often to raise awareness to young people who are maybe, some of them are many times are not engaging in penetrative sex, but they're not aware of herpes, the transmission of herpes, and some other of diseases. So we try to go to communities that may not be aware. And I started off on a syphilis awareness grant 20 years ago, where we would purposely go to our city bus station where most of our citizens who were being released back into community, where they would really literally come back into the city through our bus stations. And we wanted them to get tested and be aware of their status coming home. And that community is very appreciative that we're there upon their return to community. And so I guess some of our challenges would be, where do we locate our unit? And with it being such a large unit in a high traffic area, because many times it's a very small community, the streets may be narrow, and we may need to have as many outreach staff as we are worried about whether to locate our unit. We may need to reach out and be a block or so over from our mobile unit. And our mobile unit now is currently being staffed by our nursing department, which those are our STI nursing programs out of our STI clinics. So we go out and provide services, and we do take our lab with us. We can spin blood and identify a blood drawn specimens on the spot. So we're very intentional on rapid start and to give a person their real diagnosis on the spot. Many times it's a one-time encounter. So we are proud of having our mobile team, especially for our unhoused community and our citizens returning that may only have one opportunity to learn modes of transmission and may not be able to get to our clinics, or many times when they're returning home, it could be a clinic in their area and they may not know. So we do make sure that we educate on resources and give addresses and map where the resources are. So if you don't need us at the moment, when you see us, you'll know where to find resources. So we really try to get out and move through the community. Let me say one other thing. One of our strategies is go to our police departments and let the police department know what we're doing, because many times with non-traditional hours, we're out at midnight, we're out at 1 o'clock, 2 o'clock, and we do want police patrol there for our safety and to know what we're out in community doing, even if it's distributing condoms. You know, many times we may be in an area where it is where we have commercial sex workers, but they're citizens also. So we try to partner with our local police for our safety and to really just kind of paint a picture of what it is to have healthy community from our standpoint being the health authorities. And so that's some of our day-to-day activities for as a mobile unit. And like I say, I've been out there for 20 plus years and we're still needed. So we do collaborate internally with our medical vaccine team. So we may go out as an STI team, but we may bring Mpox vaccine, we may bring COVID vaccine, we may bring flu vaccine. So what we want the community to know that we will come to you because we are partnered with community. So that's, I think, the beauty of having a satellite mobile clinic. I've always been told we're a satellite clinic, you know, and we like to get out there in community. And I just think it's a beautiful thing when communities see you come to them. And community is very much appreciative of us. And we have, and I also want to draw attention to surveys on community who may be aware that HIV has been in community 30 years and may be a little, you know, cavalier with the medications and how people are living and thriving, that the modes are still the same. We need community to know. We need a community to know that we are trying to end this epidemic. And so I just want to say one surveyor said to me, well, Amber, you all have been out here 20 some odd years and you're taking care of us. I'm not worried about HIV anymore. And I said, yeah, but I need you to know that HIV is still HIV and the mode of transmission is what it is. So we have generations coming behind us. And we don't use the term pass the torch to the next generation. We say to pass the baton. So when you come up to my pace, I may be able to ease back. And now you carry the message into your demographic. So I think it's very important that we do intergenerational services. So that's some of my stuff. I don't want to take all the time.
No,
but I love satellite clinic. I love going to community, and I love that we have so many universities, and we also have always been aware of 50 plus transmission. So we really focus on demographics, plural.
So Amber indicated, he is the expert with the mobile unit, and when it comes to procurement process regarding the mobile unit, it's layers. We're in a bureaucratic governmental entity, so that when things need to be fixed or managed, it is a long process. So that's why we contract with other sub-recipients. If we can't, bring out the full capacity of it, they will be able to assist us with any of the testing, and some also treatment also on site. So in a nutshell, it's a process when it comes to procurement and getting additions and repairs regarding a mobile unit.
Yeah, and I think it's very important that education to community is so important with the rise of doxy prep and the way community is taking care of itself. I think the education on doxycycline and how you must finish it and that kind of thing. So I think that the education is very important as we get more tools in the toolbox. We are the expert on how you should really administer whatever the tool is into your life, whatever your lifestyle is. I think is very important. Like I said earlier, we have many rural areas where people come in just for conferences, and then they go back to a rural area where they may not know anyone else that is dealing with HIV. that they know how doxycycline should be taken and completed, and with the shortage of bicillin right now and what's going on. I think when community knows, community does better, and it's up to us to inform community mobily with our mobile clinics.
Thank you. And if anyone has any questions, we'll be around to answer regarding anything mobile today. Thank you.
Thank you all so much. So we do have some questions in the chat, but I want to just be mindful of time, and I'm going to have our next presenter present, and then what we'll do is we'll go to the questions after the next presentation. So I'm going to now hand it off to my colleague, Courtney Smith, to introduce herself, and then she's going to be talking about some promising procurement practices. Oh, you are on mute.
I am muted. Hi, everybody. I'm Courtney Smith. I am the Senior Manager, Grants and Compliance here at NASTAD. I really enjoyed hearing from Houston and LA County. I really like outsourcing the third-party sub-recipient contracting piece and the mobile unit, and what you said about passing the baton. That was super powerful. So promising procurement practices. Talk a little bit about utilizing data-driven and cost-effective approaches to deliver specific interventions through micro-planning. Could be possible to expand services without incurring large costs. Reviewing state allocation of funds to determine more efficient ways to expand maximum capacity of the most cost-effective prevention interventions. Highlight substantial differences between your state transmission categories and the national average to adjust budget to disproportionately represented groups, and how to leverage funding strategically to support syringe service programs. Next slide, please. Okay, so the first, utilizing data-driven and cost-effective approaches to deliver specific interventions through microplanning could be possible to expand services without incurring large cost. For example, a study conducted in 2018 found that New Jersey, their data showed higher than average representation of persons who inject drugs among persons diagnosed with HIV, while the ranking of the cost effectiveness of testing in non-clinical settings of those people who inject drugs fell too low to receive funding. So some possible solutions: the HD program manager implements new ways to conduct testing in non-clinical settings through efficiently expanding partner services for PWID, or the health department could introduce or expand existing cost-effective micro-planning tools to target high-risk populations that do not engage in traditional or clinical settings. So how can this be done? Micro-planning, so develop micro-plans tailored specific to communities or populations within your state. This involves detailed planning at your local level, so a lot like what Houston is doing, taking into account the unique characteristics and needs of each community. So identify locations where services will be offered, determine the most cost-effective and effective outreach and engagement strategies, and establish partnerships with local organizations and stakeholders, and identify high-impact interventions. So utilize your data analysis to really identify high-impact interventions that are most needed and likely to have a significant effect on reducing HIV transmission and improving outcomes. This could include, obviously, HIV testing and linkage to care, access to PrEP, treatment adherence support, and harm reduction services for people who inject drugs. Resource allocation, so allocate EHE funds strategically to support the implementation of these microplans. Prioritize interventions that have been shown to be effective and cost-efficient based on available evidence, and consider leveraging existing resources and infrastructure such as community health centers and local health departments to expand services without incurring large costs. I'm trying to talk fast so we can get through it. So if you have any questions, you can pop it in the chat or slow me down if need be. Next slide, please. So reaching maximum capacity of the most cost-effective prevention interventions. And this is really a deep dive of reviewing your state allocation of funds to determine more efficient ways to expand your maximum capacity of the most cost-effective prevention interventions. This is done through cost-effectiveness analysis, so evaluating the cost-effectiveness of each intervention, Stakeholder engagement, really involving stakeholders such as policymakers, healthcare providers, community leaders, people living with HIV/AIDS in the review process. And that is probably the most important piece of that, is really involving people with lived experience, people living with HIV into the process. And their input can ensure that interventions are tailored to meet the needs of the community and address underlying social determinants of health, scenario planning, and cost benefit analysis. And due to data analysis, optimal review allocation, most health departments allocate funding based on population size of groups, which can limit funds when the maximum population within that group is served. So this often includes greater funding towards the least cost-effective interventions, while the most cost-effective services receive less funding allocation due to the limited size of the population or result of data prediction of reaching maximum capacity of the group category. Next slide, please. Take a pause. So compare state data against federal data to identify substantial differences in transmission categories. To highlight substantial differences in the transmission categories compared to the national average, and adjust your budgets just to disproportionately represented groups, health departments can take several steps. So you can identify disproportionately represented groups and determine which demographic groups are affected by the transmission of the disease. This might include communities of color, low-income populations, elderly individuals, or individuals with underlying health conditions. And then do an assessment of resource allocation. Evaluate your current budget allocations and resource distribution within the health department to determine if your resources are allocated proportionately to the areas with the highest transmission rates and to the disproportionately affected groups. Doing a gap analysis. Identify gaps between the needs of disproportionately affected groups and the resources allocated to address those needs. This could include conducting surveys, focus group, community consultations to better understand the specific needs of these groups. And this is really important when you bring in the people with lived experience into this gap analysis. And then implementing targeted interventions to develop targeted interventions and public health campaigns aimed at reducing transmission rate among these disproportionately affected groups. These interventions should be culturally sensitive and tailored to the specific needs of each group. Next slide, please. So this talks about leveraging funding strategically to support syringe services programs and aligning SSP initiatives with the goals of the EHE initiative and leveraging funding strategically to state health departments can maximize the impact of EHE funding on reducing HIV transmission among people who inject drugs and advancing the broader goals of the HIV epidemic. So here are some strategies in which you can support SSPs in cost-effective and high-impact ways. Integrate HIV services, expand harm reduction services. So use the funding to expand harm reduction services offered by SSPs, such as overdose prevention, naloxone, and access to MAT. And these services not only help prevent HIV transmission, but can also address other public health concerns related to injection drug use. Enhance outreach and engagement. So allocate resources towards outreach and engagement efforts to reach marginalized and underserved populations who may not have access to traditional healthcare services. Utilizing peer outreach workers, community health workers, to build trust and really facilitate access to SSPs and HIV services. Invest in technology and innovation. Innovative approaches to service delivery, such as telehealth, mobile outreach, and digital health interventions to reach people who inject drugs in remote or hard to reach areas. Support capacity building, provide training and technical assistance to SSP staff and community partners to build their capacity in delivering HIV prevention and harm reduction services effectively. Leverage partnerships, so collaborate with other stakeholders, community-based organizations, healthcare providers, law enforcement, and local governments to really leverage resources and expertise in advancing the HIV epidemic among people who inject drugs. Advocate for sustainable funding. So really advocating for these streams of funding to support SSPs beyond the duration of EHE initiative, demonstrating the effectiveness of them in reducing HIV transmission and improving health outcomes to help garner support from policymakers and stakeholders at the local, state, and federal levels. Data-driven decision-making, use data to demonstrate the cost effectiveness and impact of SSPs on public health outcomes. By providing this evidence of their effectiveness in reducing disease and transmission and healthcare costs, state health departments can make a stronger case for increased funding from government sources. Revenue generation, develop revenue generating strategies within SSPs, such as offering fee-based services like HIV testing, counseling, or vaccination programs. And additionally, explore opportunities for cost recovery through health insurance reimbursement or partnerships with healthcare providers. Strategic planning and collaboration. So develop strategic plans that outline clear goals and objectives and strategies for sustaining SSPs over time. Collaborate with other harm reduction programs, public health agencies, community-based organizations, and stakeholders to leverage these resources, share best practices, and coordinate efforts to support SSP sustainability. And that are some few ideas with a lot of words mixed in there. So if you have any questions, feel free to reach out or pop it into the chat, and I will hand it back to Krupa. Thank you.
Thank you, Courtney. That was great. So I see a couple of questions in the chat, and some have been answered. So I just want to point that out to folks if you haven't been looking in the chat. But there were a couple of questions that haven't been answered yet. So I just want to call those out. So for Amma and Amber, has cooperation with law enforcement afforded the opportunity to offer testing in jail and correctional facilities?
We have a great relationship with our police officers, but we thought it was very important in approaching them to emphasize that all the people that we're serving are part of community that they're also protecting. So we try to partner with them protecting community from law enforcement's standpoint, and then we're the health authority. So we really try to create a collaboration with the health department for a safety and what our city could look like if they protect us and point us in the right direction of where we may need to be. And so that was our strategy. That strategy has worked for us by us partnering with the police department. And I think they very much appreciate us coming to their substations and police department before we go out to the street. And when they are checking on us, they are also coming to be a presence in a collaborative effort. So that's been our approach, to really be a partner to law enforcement. And I'm often known to say, when I see the police department, I say, oh, we have the same boss, the mayor. Thank you for being out here. He would appreciate us out here together. I do it all the time because I think we all report to the mayor, and it kind of bonds us in that sense, especially with non-traditional late hours, 1 and 2 o'clock in the morning. And so I think the collaborative approach has worked for us.
And this is kind of like a follow-up question, or question that kind of goes along with this this work. How has it been working with law enforcement in terms of some of the populations you all serve, like the folks who are in sex work or drug user, folks who are using drugs?
We are fortunate that we are not the only mobile clinic. We have one of our larger agencies here that has a 40-foot mobile unit who purposely go to the spots where their sex workers are, and the police tend to appreciate. I just can't say it any other way, that they tend to appreciate the services that are being taken out, and we familiarize them with the term commercial sex worker, and they say, "What is that?" And I said, "They're commercial sex workers." And what we were fortunate enough to make them aware of was, before we were looking at sex trafficking as much as we are now, young people who were using survivor sex to feed their siblings. And I think, and we had a lot of that when we first started going out, that many young people were out in community, with performing commercial sex work because they were surviving and are helping their siblings to eat. And when they were made aware, and I think we try to humanize those persons that others may demonize.
Great, thank you. Another question about the mobile unit program. How do you promote the location of the mobile satellite unit, and then how long do you all stay in a specific area?
Well, yeah, on our health department's website, we have put a monthly calendar for the location that we'll be at, and we have a phone number and that you can call us if you're lost and can't find us. So we put a monthly STD, STI mobile clinic testing calendar out on our website. And we
in the community too, like the day before.
yeah, and we go out to the community the day before. And what we tend to do is we may not stay on the same block for a month, but we're generally 2 to 3 weeks so that those who missed us can still find us. So 2 to 3 weeks in a specific area, and then we tend to try to move not far, even for the next site, because we want people to find us. And we also try to be aware of a person that may not want to be tested or treated in their own community, may come a community two over to get treatment or to be tested. So we're very strategic on even our calendar.
Great, thank you so much. I believe we addressed all of the questions so far. So with the remaining time that we have left, we did want to give you all an opportunity to talk with each other. So we're going to break you out into 2 smaller groups, and would like you to just talk about what things you all have been doing in your jurisdiction, and what have been your challenges. So if you could just focus mostly on these first 2 questions. And myself and my colleague, Yamil Cruz, who is on our health systems integration team at NASTAD, will be facilitating. And also feel free, if you don't feel comfortable unmuting, you can put your answers in the chat, but we'd love to hear from you all. So I'm going to go ahead and break you all off into groups. And you will be able to select whichever group you would like to go to.